Hey, in this topic, we're going to review proximal duodenitis jejunitis, otherwise known as proximal enteritis. This is inflammation of the proximal small intestine that leads to a functional obstruction or ileus. There's no physical obstruction, but just is not moving through the GI tract. This also seems to be a secretory process with a large amount of fluid secreted into the proximal small intestine that now can't go downstream, so backs up into the stomach. We believe this is related to a clostridial infection, but as you probably remember, as soon as you get to a necropsy specimen, there's Clostridia all over the place. So it's hard to verify antemortem versus post-mortem culturing. So your thought question is to review other forms of GI clostridial infections, particularly in other large animal species. Horses are generally over 1.5 years of age. They may be a risk factor for a high-grain diet. High-grain diets are a risk factor for many types of colic. And then the colic signs are acute onset, moderate to severe colic with a large volume of often very foul-smelling reflux. On rectal palpation or an ultrasound, you should see moderate small intestinal distension. These horses will often have a fever. They may be dehydrated, or usually are dehydrated, often go into shock or toxic, have an elevated respiratory rate, and tend to be depressed when they're not showing signs of pain. So they're painful, you reflux them, they become depressed. Eventually they build up more reflux into the stomach, they become painful, you reflux them, they're back to being depressed. The most difficult thing is to rule out a small intestinal obstruction without going to surgery. Ultrasound's not going to help you, radiographs don't usually help you, so there's many other causes of ileus as well that need to be ruled out, such as post-exertional, post-operative, low calcium, particularly in recently foaled mares. Peritonitis shuts down everything and makes them look depressed with a fever. Rabies can look like GI signs of colic, and blister beetle toxicosis. So as I said, one of the things we're always trying to differentiate is small intestinal obstruction versus proximal enteritis. So this chart is what we usually use. It's not 100%, but it gives us some ideas. So the biggest factor to avoid surgery is a fever. So proximal enteritis horses often have a fever, but if they've had flunixin-meglumine, or if they've had xylazine or ditomidine, you may not see that fever for several hours. White blood cell counts on obstruction horses tend to be actually low with toxic changes, and they tend to be high on proximal enteritis cases. There's a theory that the reflux in horses with proximal enteritis is more foul-smelling and in greater volume, but it's a continuum, so you can't just say at 25 liters it's proximal enteritis. One of the biggest clues is after you reflux them. Is the horse comfortable again? Does he look bright and alert? That's more likely small intestinal obstruction. They're not necessarily sick unless they have dead bowel, and then these look quite similar. If proximal enteritis horses get reflux, they're no longer painful, but they still feel like crap, so they're depressed, they act sick. Small intestinal distension, again, there's a theory that it's not as distended, so not tightly distended with proximal enteritis as compared to small intestinal obstruction, but again, it takes a while for it to become totally distended. And then abdominal tap. If you have dead bowel, you will often have serosanguinous belly fluid as it leaks red blood cells. You don't usually have dead bowel in proximal enteritis, so it's rarely serosanguinous. And you may have some mild increases in white blood cells and total protein. Those can be quite variable in small intestinal obstruction. Complications are quite significant. Gastric rupture is common due to the large volume of reflux. The horses can become very toxic very quickly, especially if it is a clostridium, and they can get laminitis. The bowel that's inflamed and not moving can stick to other parts of the bowel and get adhesions, as in the diagram at about 9 o'clock. Myocarditis and arrhythmia is related to the toxins, hypovolemic shock due to the large volume of fluid sequestered, and death. In the southeast U.S., the syndrome seems to be much more severe, and these horses will go into renal failure and laminitis within hours. Knock on wood, we don't usually see that bad of a syndrome here. They'll last for days before going that direction. So again, prognosis is better in Minnesota and in the UK, where some other studies have been done, and worse in the southeast US. In our area, the biggest concern is treatment can be very expensive, as the horses cannot take anything in by mouth, so have to be given IV fluids, which for a horse can add up quite quickly, and eventually need to be on parenteral nutrition. These need to be referred. As we keep mentioning, any horse that's refluxing really should be at a referral center to maintain hydration. It's very, very difficult to manage that in the field. Sometimes the stomach on these is so distended that it's hard to pass the stomach tube, and you always want a stomach tube in for the trailer ride so their stomach doesn't rupture. So it can help to add 25 to 30 mils of lidocaine through the stomach tube, kind of numb the cardiac sphincter, and then you can push through a little more readily. So if the horse is really painful, you're suspecting something like this, and it feels like you just can't get into the stomach, whether it's this condition or another one, try adding the lidocaine. Hypertonic saline is probably a very good idea for these, just to try to start maintaining support for the kidneys and other organs. And then once they get to the referral center, we'll finish up with more IV fluids, make sure their stomach stays decompressed, probably put them on some motility agents. Here we use lidocaine IV based upon research that I did during my residency. They are treated for laminitis. This horse is standing in ice boots, given antibiotics to counteract the Clostridium. So remember what kind of antibiotics would counteract Clostridium. And then they may eventually go to surgery to rule out an obstruction or to decompress the small intestine. That has its own complications. We try not to go unless we need to, but it is a good fix for these sometimes. There's no known prevention. As I said, colic is associated with high-grain diets, so it's good to keep especially the corn out of the ration as much as possible and use other calorie sources as needed.